right, so I know Dr. Krishnan and I speak about this often. We see that most of what we discuss is really meaningless unless we have data to support it. So I think he challenged me by picking up ALI, because the data, in my opinion, although the efforts are there to try and do something proper, it's really way off. So no relevant disclosures. So acute limb ischemia, in terms of the outline of what I wanted to say, we have about 10 minutes to get through some data, and he wanted case-based, so we'll see what we can get through. So I'm going to review some guidelines, look at what some of the results are, and maybe a recommendation of an algorithm, and maybe set up the platform so the next speakers, I see they have some interesting talks to maybe complement the case that we have. So the real question is not so much, thrombectomy, lysis, combination of both, or even operative, which is not part of the protocol. The real question is, I think, more important, how much time do we have? Is the limb really salvageable? Where's the location of the limb? And then the real question, which a lot of the data does not get to, at least until this point, is, are we talking about native anatomy? Are we talking about previous interventions in that leg? Are we talking about those previous interventions being surgical, vein versus thrombotic, thrombosis of synthetic grafts? So ultimately, a lot of it has to do is what that clot looks like, where did it come from, how old is it, and what is the underlying etiology. Approach questions would be lysis overnight versus on-table thrombectomy versus combination of both, which is the topic, and what is the optimal device to do that. I'm going to defer that to the next group because I think it's too much to put into 10 minutes. So the real question becomes, if you look at some, these, I'm going to start with some slides to question the data that we have, and this way when I review some of the data, we can see where some of the flaws may lie. But so acute limb ischemia, I think for the most part, we know what that is. The real question is, if you're categorizing people in these trials, where do they fall? Because the real benefit we can provide is for the people whose leg is really threatened. If the leg is really threatened in terms of Rutherford 3s, if they fall into the trial or not into the trial based on the decision process, that's really where we have the biggest impact. And I'm not certain that the studies that we have really dictate to that group. So we also want to look at that in terms of pre-existing pathology. So Rutherford classification is the system we all use. Most of the studies we say are really 2As and 2Bs, but where we make the biggest impact is the third group, which is the Rutherford 3s. Those, for the most part, although it states it's not salvageable, I can tell you most of the impact that we can have is on the Rutherford 3s, because if they're just tipping over into that group, if we can reverse that group, the limb salvage benefits are greater. So what do we have in terms of guidelines? AHA, ACC guidelines, not too many years back, basically stating that the third group, the Rutherford 3s, which are irreversible, which, as I said, is not always necessarily the case, should be primary amputation. I think we could do a little better than that. I think that's the group that, if we're talented enough, we can potentially reverse and make the most benefit for. So, European guidelines. It's sort of interesting in terms of the level of data as a representation of what I said earlier, that most of it is not there yet. If you look at some of the recommendations, the interesting part is if you look at the data that they use for their guidelines, pretty old. For patients with Rutherford 2A, acute limb ischemia, is recommended that percutaneous catheter-directed lysis considered as an alternative to surgery. I think we've passed a lot of that from now. I think really the real question is, and I guess the answer to all of it is, it's not so much whether it's thrombectomy, lysis. I think to really address this group, it's use everything that is available to you to get the best results, because I don't think we have an answer to the question of what is best. Aspiration, mechanical thrombectomy should be considered as a 2A level C data, which is really not great. So, overall outcomes. Limb salvage rates, 50 to 85% traditionally, all comers. Again, most of these studies will look at 2As and 2Bs, which I think skews the numbers, because the real limb salvage rates, if you look at some of the Rutherford 3 tip-overs, can really have limb salvage rates that are not as beneficial as what we see in some of the studies. Mortality rates still high. They're usually a sick group of individuals. So what do we have as broad categories? Surgery, more expeditious, which is the philosophy most people have now. It's greater morbidity. I'm not sure about the most expeditious part. I think in the hands of people that are experienced with catheter-directed thrombectomy, lysis, combination thereof, these hybrid maneuvers can be pretty expeditious. And then in terms of catheter-directed therapy, we stay as less expeditious, Less morbidity, probably to a certain extent, sort of bleeds, but it's really, question is whether it's pharmacologic, mechanical, or mixed. This all started, and we haven't made many changes over the last 3 decades. This all started with the STYLE and TOPAZ trials. We were trying to look as alternatives to surgery using lysis, and at that take-home point at that time, 3 decades ago, was basically if you have the time allotment, a less morbid approach can be lysis. So has a lot changed over the years? Interestingly enough, not much. You know, in terms of studies, if you look at some of the larger volume studies around the world, the quality of the evidence is graded as low and moderate at best, with the not real change from the TOPAZ and STYLE trials. In terms of treatment algorithms, lysis still a big part of it, can be a contributing factor, hard to decipher from most of the trials that we have. And why is that? Because as the technology has improved, and this list is more extensive now, I know there's another speaker, they're going to address some of this. We have a lot available to us. We still don't know which of these are best. It's basically user dependent in terms of familiarity with treatment, but we have a lot of tools in our availability, let's say. So real question is, nothing's really comparing these head to head with each other and in the same clinical setting. So 2024, study out of Japan, 11,000 patients. Ultimately, what their response was is that you're probably better suited with open surgery, which was interesting, except if you're in the group with PAD, which I think is the most challenging group. Those are the ones where all the skill sets of everything we've spoken about this morning and yesterday is superimposed upon with lysis, which is putting you under the gun in terms of being expeditious about getting things done. So I'm not certain it's a fair assessment, putting all players together, because native anatomy is one thing, but pre-existing PAD, which is what accounts for a significant portion of these patients, is a big difference. So we have a tendency toward technical success that's been improving over the years. Again, it's whether it's the safety profiles for the devices have improved, catheter-directed therapies become more expeditious, and we need studies to address all of that. So ultimately, treatment outcomes, we look at these as groups. We look at them as what are they comparing them to? Is it just a study of the device itself? We don't have anything to compare devices to other devices necessarily of any benefit. So what do we find? We find that some of these devices compared to open surgery are potentially better in terms of morbidity and complications, in terms of limb salvage rates. They're matching. Nothing has really said that anything's better to date. So I think the closest we've come now is the STRIDE trial. STRIDE trial gave their initial results in terms of their ability for limb salvage. And actually, you could see it's not a very large study, 120 patients out of 16 sites. It's not a tremendous amount of people, but they reached their safety goals. Their success in terms of the initial study to now, up to 365 days. Technical success, 96%. Patency of what was done is 89%. But as you can imagine, with 120 patients, considering all comers, they did the best they can in terms of localizing the disease, but we still have a way to go. They categorize it into, what the thrombus is, where the location is, are there tandem lesions, and ultimately, their category, as I said, like even this trial, which is device-related, specific to one device, 2B and 2A. 10% of them were considered viable, which I wonder what their entrance into this would be. And again, so limb salvage rate at 365 days, 88%. Seems very promising for where we stand today. Mortality rate at 65 days, 12%, similar to what we had before. Quality of life improvements. What I think we need, similarly going forward, for just a quick review of a case, is these sub-analyses. At this point, they're looking into subgroups based on whether it's a bypass, an in situ group, whether lysis was used as an adjunct or not. So we're still far off in summary for where all the results lie. And this is not just here in the US, it's just European countries as well. There's a prediction at 90 days, amputation-free survival, not really being different in terms of groups that we're in. Overall, we see 86% amputation-free survival at 30 days, 82% at 90 days. And can this be done with open therapy versus hybrid versus endovascular? Not much of a difference. Again, too many variables to say. And then contemporary practices for acute limb ischemia, you can see that there's a transition over time, but ultimately they're all successful. It's more user-dependent in terms of what we have. So what of our recs to date? If I have to give any, it's basically to first determine the age of the thrombus, determine what the native circulation is like if you can, if there's pre-existing images. Was there previous intervention, either stent, graft, is it an embolus, is it a thrombus? And don't declare something unsalvageable unless you're really sure, because that's the group that benefits the most. Confirm that lysis is an option, because it's always a great bailout. How quickly can you get the circulation restored is really the question. Know what it is that you're embolizing if you can, because the bailout from that is really dependent on what the age of the thrombus and quality of it is. Always consider filters as an option, and know what your runoff is if you can determine it. My algorithm is basically pretty straightforward. It depends on the stage, depends how quickly you can do it. We consider endo first for everything else, and only save the amputations for the critical ends. So, one quick case to bring as a stimulus, I guess, for the subsequent speakers, and I think it addresses some of the issues of what I was referring to earlier. We had a case just a week and a half ago. Someone came in, previous endo, graft repair of the aorta, ended up with a cold right leg. The interesting part, it started about 3 weeks before, if you take the history closely, so you know we're dealing with some thrombus that's potentially acute on chronic, the chronic being potentially 3 weeks. The question is from where? No AFib. You see a lucency in top right field, limb of the aortic graft has something in there. That's the only potential source that we could see. Why that would be? It's odd, it's peculiar, because you see on the coronal sagittals, everything else, it's not really kinked, it's not twisted. His risk factor is that he potentially smokes, so does that make him hypocoagulable? But this lesion here, as the potential etiology, it does not look like something that should induce a thrombus in any way. It's not kinked, it's not twisted, there's no ledge. But ultimately, as you see on the axials, popliteal's out, origin of the tibials are out. So you have an image like this. I say this as a stimulus for others. What do you do with this? Is a class, he started as a 2A day prior, now he's a 2B. His foot's getting cold, so it's a little bit immobile. We have a target of the PT, but barely audible signals in his foot. So do you pursue this with a catheter? Do you pursue this with lysis? Do you pursue this with surgical options in terms of cut down and taking the tibials out? Understanding there's risk of embolization with all of the above. Do you select out one vessel right now as runoff? If you delay out the pictures, you probably have an AT, but you really have a single vessel PT. Do you try and open up the AT and perineal to give them the extra jolt, or do you go for the single vessel peritoneal PT and risk embolizing something down to the ankle? So as you can see, there's a lot of variability when you're dealing with an acute limb. And in this case, although some of the variability is what I discussed, it's actually, the anatomy is not really consistent with any previous PAD. So if you add on an element of PAD on top of this, you can see what the complexity levels are. So as an example, we chose non-operative, we chose catheter-based, we tried an aspiration catheter. 6 passes the aspiration catheter, absolutely no change whatsoever. I'm not sure what my co-panelists, anyone in the audience would do, but at this point the question is, do you change aspiration catheters? Do you go for something different? Do you go for something that's not aspirational and more breaking up the thrombus? And it starts making me question, was it 3 weeks old? Had they been there longer, or is there further clot? So we opted to lyse. After 60 overnight lysis, 16 milligrams total, this is the picture we're left with. Still residual clot. For a small segment of clot, to me, 60 milligrams overnight, if it's not clearing it, it's going to be chronic to a certain extent. So do we leave this, put him on an anticoagulant, just wait to see what he does? Do you risk leaving that behind? I think this area here is probably induced from the aspiration of passing it a couple of times. And you have residual clot in the AT, and you have clot in the pop. So what does one do for this? Ultimately, we put in some scaffolding. We chose one of the vessels, put in some scaffolding, left this behind because we didn't think it was flow limiting. Not sure it's the correct thing to do, but ultimately got back palpable AT and PT. So, remaining questions are, as I said, as a closing statement, how old is the thrombus? Is lysis better for chronic disease? Is it worth the trauma of doing multiple passes versus adding on a subsequent device? And is suboptimal results better than a perfect operative result with no implants, accepting the morbidity? And is the goal to be least invasive, or is it to get the best results and or to avoid further interventions at 1 year? I like to say I'd have answers for all these, but I don't. I think it's more of a provocative statement by subsequent speakers. Thank you.